Great. Thank you so much, Nadine. That was amazing. You're right. We haven't talked about this a lot before, but certainly it is a huge issue right now for HRSA in particular is looking across health systems, how we can support wellness. And our organization, we try not to send any emails in the weekend or after hours. And we've taught everyone how you can do the delayed email send. So you can write the email and you can have it sent on Monday morning at 9 a.m. or whatever. So there are lots of little tricks too to reset expectations. So thank you so much. It is now my great pleasure to introduce Jim Raper, who is a professor of medicine and nursing at UAB, the director of the HIV clinic at UAB, has doctorates in nursing, is a lawyer. He's a man who has so many accomplishments. He'll be talking to us today about really engaging patients that are out of care. So very excited to hear from you today, Jim.
Thank you, Dr. Shaver. So again, I'm very happy to be here to talk about engaging out of care patients. I want to thank the program organizers for inviting me to do this presentation. And I also want to give a special shout out to Stephanie Christ for her technical assistance throughout this entire project of getting this pulled together for today's presentation. Thank you, Stephanie. So I have no financial disclosures. After the presentation today, you all should be able to identify the 5 stages of the HIV care continuum. You should be able to identify how data to care supports the HIV care continuum, and you should be able to order the 6 steps to get patients back into a healthcare practice. I thought that I would share a photo of our new clinic here at the University of Alabama at Birmingham, the 1917 clinic, which was originally founded by Dr. Michael Sagg in 1988, 31 years ago. I've been in collaborative practice with Dr. Sagg for the last 26 years, and I am the director of the 1917 clinic. This is the picture of our new clinic. We moved in here in December of last year during the height of the COVID epidemic, and we are co-located in this building with Birmingham AIDS Outreach, which is a community-based organization providing care to persons with HIV and to the LGBT community. We occupy 50,000 square feet of this new facility, and we're just delighted to be here. So the essence of HIV care is antiretroviral therapy, which improves individual health and prevents the transmission of HIV. The National AIDS Strategy emphasizes that it's important to increase access to antiretroviral therapy and promoting adherence to those medications to achieve and sustain long-term viral suppression. If individual and public health benefits of antiretroviral therapy are to be realized, persons with HIV must be linked to an engaged and continuous lifelong HIV care. So most of you, I'm certain, are familiar with the HIV care continuum. It's a framework that models the dynamic stages of HIV care, and the 5 main steps are depicted as cross-sectionally as an HIV treatment cascade. The steps are depicted in this diagram or illustration. The diagnosis, of course, is essential with HIV, linkage to care, the reception of medical care, the retention in medical care, and finally, to achieve and maintain viral suppression. Nothing new to all of you folks. So in preparing for today's presentation, I did a good bit of research into the current state of engaging or re-engaging out-of-care patients back into care. And I found a very important systematic review of research that was published in 2016 by Hege and colleagues. And what they found is that, their purpose in this systematic review was to identify best practices for increasing linkage, retention, and re-engagement in medical care for HIV, for folks living with HIV. What they found were 5 evidence-based interventions and 5 evidence-informed interventions. 1 evidence-based intervention had effects for linkage. 1 evidence-based intervention, which is commonly used now throughout much of the United States, you may be familiar with it, is called ARTIS, and it looks to both affect linkage and retention in care. There were 3 evidence-based interventions that affected retention in care. And I might point out that these primary intervention strategies included the co-location of HIV services, the interactive notification system to alert providers of missed visits. And we certainly know in our clinic that if a patient misses a visit and they get a call from their provider, it has significant effect on the patient, and they realize that we missed them and we were expecting to see them. And then the last is encouraging patients in person and telephone contact to keep appointments, the enhanced personal contact model, if you will, which I think is getting a lot of integration into the care of persons with HIV. However, the systematic review of research failed to identify any evidence-based intervention that had effects on the re-engagement of persons to HIV care. So the continuing challenge for us then is re-engaging persons with HIV who have previously been in care and linking persons with HIV who were diagnosed but never successfully linked to care. The CDC recommends the use of surveillance data to identify and re-engage those persons into HIV care. So identifying best practices that successfully link never engaged persons or re-engaging persons lost to care remains a crucial need. And we'll talk about today this process called data to care. We'll also explore some perhaps things that can be done on the local level with each entity, each clinic. And so data to care is a public health strategy for guiding re-engagement in care activities. So before we talk about data to care, I wanted to talk a little bit about what a local clinic might be able to do to re-engage patients. First, I think it's important that the organization create a list of patients that perhaps were seen within the last 24 months, but not within the last 12 months. And most of us have the ability to generate that type of list. Then, using that list, the organization might prioritize the groups of patients that they want to target for re-engagement strategies. That targeting of the patients who are out of care or who are no longer in care could be based on let's say, acuity, patients who have low CD4 counts, or patients who had their last virus that was not suppressed. Or simply they could target patients who were relatively recent no-shows or cancellations. It's also essential that the clinic develop tracking activities for how they're making telephone calls or sending emails and letters so that they can have some idea in terms of the amount of work that has been invested in contacting patients and what the status of the contact of those patients might be. If clinics have sufficient resources, they might even make home visits to the patient's address of their last known address. So again, the roadmap for re-engagement at the local level would be to identify the persons not in care within the last year, determine which group of those patients that they want to really target on, then get the information analyst to export the patient's email addresses. And many of the systems today contain patient email addresses. And this is a very fast, simple way to move forward. Get those email addresses exported, create some email messaging. And it's really important, I think, to customize what you're going to say in an email to a patient. Something like, we've missed you, we care about you, where have you been? Looking forward to seeing you. Those types of things that might catch a person's attention very quickly. It's also important in the body of the email to make a recommendation that to patients to take action. For instance, call today, schedule an appointment. Those types of very specific things that a patient can do. We also want to encourage clinics to make it easy to book an appointment. Some clinics today have priority online scheduling. Unfortunately, here at UAB, we don't have that ability, but I know that some clinics do have the ability to schedule online. It's also important to let patients know if you have expanded or you have new flexible hours. What we have found is that some patients fall out of care simply because their work requirements are such that they're unable to come to clinic without getting points or being penalized because they're missing work. And so the development of expanded hours or flexible hours might be something to let patients know about. It might also be great to let folks know that telehealth visits are now available. And then once the appointments are booked, it's essential that the clinic send appointment reminders. And it would be best, I think, if an organization could find out and solicit from the patients, what is your preferred way for us to contact you? Do they like snail mail? Do they like the postal service? Would they prefer text? Would they prefer emails? What do they prefer in terms of clinic reminders or appointment reminders? So leaving what the clinic can do standalone activities, the CDC recommends regional surveillance to identify out-of-care patients. And I know that some clinics are involved with regional surveillance projects. A quick trip to PubMed will provide a list of manuscripts of jurisdictions that have used the data to care processes to bring patients, to identify patients and to get them back into care or to link them following their diagnosis. It's very sophisticated, and we're going to briefly talk about the data to care process. It is as I said previously, it's a public health strategy. It was developed by the CDC and HRSA that uses HIV surveillance data that is available to jurisdictions like the state health department. And it uses other data to support the HIV care curriculum by by identifying persons with HIV who need medical services or other services and facilitating the linkage to those services. The goals of the data care strategy are to increase the number of persons with HIV who are engaged in HIV care and to increase the number of persons with HIV who have sustained undetectable viral loads. Now, laboratory reporting to health departments of CD4s and viral loads have been implemented probably throughout most every jurisdiction in the United States. So when a reference laboratory performs a CD4 or a viral load, that information is automatically and by requirement transmitted to the state's Department of Public Health for surveillance. It's done in a confidential way, of course, but using that data that is mandated to be reported, they are then able to identify persons with HIV who never linked to care, because in addition to having the original diagnosis data, they also have the CD4 and viral load data, so they know if patients are continuing to have the markers, the viral loads, the CD4s, or the process has just stopped. So they're able to then identify persons who were diagnosed but never linked, or those who were linked and now appear to be out of care. Jurisdictions can help ensure improved health outcomes and reduction in new HIV infections. Of course, if patients have sustained viral suppression, they're not able to infect other individuals, and they can use that surveillance data that is available to the jurisdictions to trigger linkage and re-engagement research, outreach, and to assess participation in care, so they can keep track of who is in care and who has potentially fallen out of care. They also can link their jurisdictions with other state jurisdictions, so they could potentially see that a patient has left, in our case, Alabama, and is now receiving care in Mississippi or Louisiana through these very sophisticated surveillance systems. At least that's by design. So again, talking about the design and the scope of data to care, the activities include using that surveillance data to identify the persons with HIV who are not in care and linking them. Persons with HIV but not virally suppressed can also be targeted. So if the jurisdiction identifies an individual who consistently is having viral loads reported but has failed to achieve viral suppression, resources can be targeted to that individual to investigate what additionally might be needed to help them achieve the goal of viral suppression. The surveillance data can also be used to identify pregnant women and mothers with HIV and their exposed infants that might need coordinated services, such as perinatal HIV coordination services. This diagram basically depicts what the data to care process looks like. And as you can see here, the surveillance data is reviewed by the health department authority. They work in conjunction with local clinics to be certain that the information is provided. They look for patients who are previously seen in a clinic, but they're no longer getting their data. They can investigate the persons on the list. They prioritize the list, perhaps based on viral load, and they share that information with their own. They share that information with their own field support. So, for instance, in Alabama, we have some folks working in the field who can go to the patient's last known address and try to see what might be happening and if they could help facilitate getting the patient back into care. They might also find out if the patient has moved out of state or something else has happened with the patient. All done with the utmost confidentiality. I wanted to talk just for a few minutes briefly about what's happening in Alabama, particularly here in Birmingham with the data to care experience. So data to care in Alabama is the Alabama Department of Public Health, and Birmingham is located in Jefferson County, Alabama. And so the Jefferson County Department of Health, they focus on follow-up with patients who have been out of care for greater than 12 months. So once they identify those patients are targeted. And the Jefferson County Department of Health employees, they contact the linkage and retention coordinators here at 1917 Clinic to help get those patients back into care. I will tell you that we have made a substantial investment in linkage and retention to care at 1917. We have 5 full-time employees who focused all of their efforts on linkage, retention, and care activities. And so having a relationship with the Jefferson County Department of Health and our linkage and care coordinators is essential for success in this project. The 3 entities, Alabama Department of Public Health, Jefferson County, and 1917 are involved currently, and they have been for about the last 2 years, with the HRSA Technical Working Group to focus on HIV Ryan White provider collaboration to enhance the provision of capacity to take care of these patients. And this has been going on for 2 years. I would never want to underestimate the amount of time and resource investment that is essential to making data to care work. The group is focused on increasing collaboration and coordination between the 3 organizations and learning from the data to care organizations in the South. I know they've been working hand in glove with the group at Georgetown and a group in Louisiana. Our group is beginning to work on new processes to send data to Alabama Department of Public Health with a list of 1917 patients that we've identified as being out of care to help hone this process. There was a setback here in Alabama. The epidemiologist who was working with the Alabama Department of Public Health suddenly died. And so the Alabama Department of Public Health was without an HIV epidemiologist for a period of time. I understand that a new epidemiologist has been identified and is now working with the group to try to use this data efficiently. I think it would be safe to say that in talking with various people about the process, it is a frustrating process at the very least. There are many technological hurdles to overcome of getting the data and making the data work. And so I think with dedication of both clinic staff and the jurisdiction, the state jurisdiction and the county jurisdiction individuals, this is a process that can eventually be successful, but it is not something that happens easily. So just to review in the short time I have left, the 5 stages of the care curriculum: diagnosis, linkage, retention, adherence to antiretroviral therapy, and viral suppression. We've talked about the 6 steps that a clinic can use to get persons with HIV back into care at a local health practice, and through using primarily email and telephone contacts. And then we've defined how Data to Care supports the HIV care curriculum by identifying patients who are in need of HIV services and getting those patients linked back to the facilities that can provide those services to the individual. So I think I've run out of time, and we're ready for some questions and answers.
Great, thanks so much. So the first question that came in was towards the beginning of your talk. Are there actually data that show that it makes a difference whether the provider calls versus someone else in the clinic contacts the patient to reschedule?
So I don't think there's published data on that. It certainly would be a good demonstration project, but I can tell you anecdotally that when I call a patient and demonstrate my concern for that patient, it has a significant impact. It's palpable when a patient says, "Dr. Raper, I wasn't expecting a call from you," and I say, "No, but I was expecting to see you today. And let me, and so to answer the question, I don't know that there's data, but I think there's certainly room to explore the situation. And I can tell you from my personal experience, it makes a big difference. It also makes a big difference for me, Dr. Shaver, when a patient comes to clinic and they have missed the last 3 appointments, and I say to them, "Gosh, I'm so glad to see you. I've been wondering where you've been. Gosh, it's important for you to come to your appointments." So I think that providers can make a huge difference, but I also know it's very time consuming.
Yeah, no, I completely agree. I, in clinic, always do that, usually after they're 20 minutes late for their appointment. And so at that point, I've got everything in my head of what they needed to have done that day. So I'll call them and say, "No, I want to talk to you about this and that. I don't know what you had going on. And can you come and get these labs that I know you're overdue for now?" So you can actually get a little bit done in like a 3-minute conversation with the patient. So I agree. I don't know about the data, but I definitely do it. And people are always pretty excited to hear from me for whatever reason. Okay, so another question was about people want to be able to text message patients that are out of care, but their administration is concerned about HIPAA issues. Have you seen that, or how have people handled?
Well, so I work at UAB. Our privacy department has issues about everything. And I think the key to it is getting the patient's permission, asking the patients, "How do you want us to communicate with you?" And you know that there is potential for someone to receive this message. "No, I'm the only person that uses this cell phone. No, I'm the only person who has access." And so I think a lot of it is what you work out with the patient. And sometimes you have to get them to sign forms to allow you to do that.
Yeah, I think
As an attorney, I can tell you that the law is real and bad things can happen, but I think keeping the patient the primary focus, you can accomplish your goal.
Great, and people have put in the chat various HIPAA compliant messaging apps and other things. So definitely worth looking at. I know for young people, we had heard in a study we did years ago at HRSA that it was just hard because their cell phone number kept changing. So they would agree to be contacted on Instagram or something else in a way that was discreet to the client. So definitely possibilities. A bunch of people have put things in the chat that are working well for them. in terms of other questions, someone just said, I'm missing something. If an individual are getting blood work to monitor their viral load of CD4, they must be linked to some kind of care. I think this is around your using your surveillance data. Can you talk more about that?
Well, again, if patients are getting that surveillance data, that's the very point of having the surveillance data. So let's say 1917 clinic, we think this person has been lost to follow-up. We have no idea where this person is, but our jurisdiction knows that they're getting care, so they can provide that information back to us, and without divulging any confidentiality, and say, 1917 clinic, we know you think this person is out of care. We have evidence to support that the patient is engaged in care. You can take him off your radar.
Right. What about people that keep getting their medicines refilled and you keep getting their refill requests, but they never come in to get labs or see you? Like, how do you manage that? Because over time now, it's been 2 years and you haven't ever seen the patient. They don't pick up their phone or respond to letters. Refilling the medication?
So we do not continue, we have a protocol here. We do not continue prescribing medications to patients who are out of care. That is medical malpractice if something goes bad for that patient. So 6 months, you got to be seen. If you're not seen in 6 months, you can get a bridge for a month. And after that, they're notified, the pharmacy is notified that there will be no additional refills, and they can communicate that to the patient.
Great. It looks like we're just out of time. A lot of people had that same question, and some people said they do the exact same thing you do. So that is terrific. So thank you so much. That was just a wonderful presentation and a great run of what is known to date. At this point, I am going to, we are going to have a break until 40 minutes after the hour, whatever hour you happen to be on. And then my go-to guy, when I have questions with STIs, is going to be giving us an update on all the new things that changed in the latest set of guidelines. So don't forget to come back right at 10:40. Thank you so much. We get a 20-minute break. Take care of yourself, walk around, get something to eat or drink, and just take a minute away from your email if you can. Thanks.